Hello, everyone. I'm going to go ahead and start the endocrine lecture. And get this going. We'll start with diseases of the posterior pituitary. And under this category, I'm going to cover SIADH and diabetes insipidus only. So it's just one slide. It looks like a pretty busy slide because it is, but I just kind of want you to learn these as a comparing and contrasting. It's super helpful to learn them that way. And just whatever I talk about is all you need to know. The book goes into obviously much more detail, but at this point, this is what I need you to understand about it. So let's talk about the syndrome of inappropriate antidiuretic hormone versus diabetes insipidus, SIADH. So how I kind of remember, like when I kind of think about these two, syndrome of inappropriate, I think of the word inappropriate, and often inappropriate means too much, like too much drinking, too much promiscuity, too much of something, and we tend to call that inappropriate behavior. So syndrome of inappropriate ADH, inappropriate water retention due to doing too much antidiuretic hormone. So when you think of SIADH and diabetes insipidus, they are the opposites of each other, and you need to write down and remember these are an issue with antidiuretic hormone, either too much, inappropriate, or too little, ADH deficiency. Okay, so let's start with SIADH. So first of all, like I said, it's important to know what it is. What are the causes? Overproduction of antidiuretic hormone by the pituitary tends to occur in a patient who has head trauma and the pituitary gland is compressed or affected in some way. Cancers, or should just really put like a pituitary tumor, which are sometimes cancers and which sometimes aren't. But often pituitary tumors would be something that can cause that. In a hospitalized patient, we see it in more of a patient who maybe has had some head surgery or something going on with their head that they are getting pressure on their pituitary gland. Clinical manifestations, super important to know. Certification questions are going to focus on these clinical manifestations and labs. So instead of memorizing them, try to make sense of them. The first one being thirst. Just kind of keep in mind thirst, any type of antidiuretic fluctuation. Obviously, it makes sense. Both of them are going to be present with thirst. Neurological changes from hyponatremia, over here, neurological changes from hypernatremia. So what to keep in mind here, anytime there's going to be any changes in sodium, and I'll explain to you why those changes of sodium occur. Any changes in sodium, that especially if there are quite a bit of change in a sodium, remember we get fluid shifting because of the sodium, the hypo or the hypernatremia, and the brain cells don't like that. They don't want all the fluid shifting intracellular to cellular, and hence patients with hyponatremia or hypernatremia tend to have neuro changes. They get confused, they fall, they have numbness, tingling, any neuro changes that you can think of. Okay, so this is inappropriate water retention. They have a lot of water retention because they are not diuresing. So if you know what SIADH is, you understand that they have weight gain. Depending, they can have some edema, but that makes sense, right? They could have some edema. And they have hypervolemia, a lot of volume in their bloods, a lot of water. But they have too much antidiuretic. They have too much against diuretic, not diuretic. And so they get decreased urine output. So think of them as these big fluid-filled people and no water coming out. So, I don't have a mouse with this, so I'm never going to be able to draw. Okay, so just write down like a kind of like a big fluid filled person, and then they're holding onto water and they're not able to urinate. So that's important picture to keep in your mind, because then the lab work makes sense. They are hyponatremic because they're loaded with water. So it dilutes their sodium out. This can be serious. So anybody who has sodium levels between about 110, when it starts getting, that should say 115, 110 to 115, it can cause some severe and sometimes irreversible neurologic damage. So we'll talk about correcting sodium a little bit too. So we have to keep an eye on their sodium. Other than hyponatremia, they have a decreased serum osmolality. So remember osmolality, if you want to change that word in your mind to concentration, it's the same thing. It can kind of help understand it. So the concentration in the blood is decreased, okay? Why? Because they're loaded with water, so it dilutes everything out. But when they do pee a little bit and they have a few little milliliters of blood, urine, that urine has a high specific gravity and high urine osmolality because it's super concentrated. Concentrated urine, watery blood, sodium is diluted out. Got to know those. What about management? So we want to treat the underlying cause. We have to figure out why somebody has SIADH. If it's severe, we would restrict their fluids, 800 to about 1,000 milliliters a day if they need that. We want to replace sodium. And how we replace sodium in a patient is we actually give them 0.9 normal saline. Right here is what I should have put 0.9 here, but add that. So we give them 0.9 normal saline, which is an isotonic solution. There's enough sodium and chloride in it to replace it. However, if it's severe, and there's some guidelines, you don't have to worry about that at this point. You'll learn that in your NP classes. If it's severe, we have to replace their sodium with a higher concentration of sodium. So we would use a hypertonic solution, which would be 3% normal saline. Okay, so generally it's an isotonic, but if it's severe, we give them a hypertonic. Keep in mind, if hyponatremia is corrected too rapidly, we can give the patient what's called central pontine myelinolysis. So what happens is they start having severe neurosymptoms. They get what we call an osmotic demyelization. So their nerve endings start to, the myelin sheaths start to come off. And what happens is the white matter in the brain, that starts to become demyelinated. And hence, if we give sodium too quickly, we put 3% normal saline in and we infuse it too quickly. And any of you who are in the ICU, or especially at a neuro ICU, a trauma ICU, you see this used and you know that it's infused in very slow rates, a few milliliters every hour, because we don't want to cause that myelinolysis of their white matter in their brain. If we do, they're going to start having neurosymptoms like confusion, delirium, hallucinations, and any neurosymptoms that you can think of. The last one here is diuretics. So we want to get that water out of their vascular system and get it out of their body. So diuretics can be helpful. Remember, add here to monitor their sodium, monitor their neurosymptoms. Okay, so think about the SIADH person. Now it's the total opposite for diabetes insipidus. Excess water elimination. Now you got this dried out person, and just make a picture of this dried out, skinny, shriveled up person with just water just pouring out, due to a deficiency in antidiuretic. Not too much, but they don't have antidiuretic hormone. What are the causes? Well, sometimes it's idiopathic. We don't know. Damage to the hypothalamus, pituitary, same causes. They have a tumor on their pituitary. They've had head surgery. Same thing, but it can cause the antidiuretic hormone to be deficient. Signs and symptoms, we kind of started covering. We just talked about thirst being present. Both present this way. Neuro changes from hypernatremia. Why do they have hypernatremia? Think about all the water leaving their blood, and so their sodium stays the same. We draw their blood, and it looks like, it appears that there's a ton of sodium in there because it's not being diluted by the water because the water is out. Polyuria, right here, circle it. This is often how we see it. They have a foliant, and it's just like pouring clear, large volumes of clear urine, 8 to 12 liters a day. I mean, you can't keep the Foley bag emptied quick enough. You empty the whole bag and you turn around and the bag is filled. So a large amount of excretion of clear urine, star. Well, certainly they're not going to have weight gain because they're losing water. So hence we would tend to see weight loss. They're losing water in their vascular system. We're going to see hypotension and signs of dehydration. So over here we see signs of fluid volume excess and hypervolemia. Here we see signs of fluid volume deficit and dehydration. Lab, hypernatremia, because of what I just talked about. Increase in serum osmolality. Now think about the concentration of the blood. Like I said, all the water's leaving, but the sodium's staying behind. So they're going to have hypernatremia and a lot of concentration in their blood. Decreased urine osmolality. Their specific gravity is low because their urine is like pure water. Specific gravities of 1. They're so low. Management, we want to treat the hypernatremia, so monitor sodium, watch for neuro symptoms, treat the hypernatremia, give antidiuretic replacement, administration of a synthetic vasopressin analog, demopressin acetate, which you may know is DDAVP, which is a synthetic antidiuretic hormone, so we can get their pituitary working again, and that's the treatment of choice, important to know. And certainly, that's spelled wrong, sorry, we want to treat the underlying cause and see what is actually causing it, so we can get rid of it. Okay, thank you very much.